Well, good afternoon again. My name is Jenny Baumgartner, and I will be the moderator for the session today. So, on behalf of the NIH Office of Disease Prevention, it is my pleasure to welcome you to the Prevention in Focus webinar series. So, previously known as the Prevention Scientific Interest Group webinar series, the Prevention in Focus webinar series features talks from prevention scientific experts and thought leaders who are making advances in public health. This webinar series provides an opportunity for the broader scientific community and members of the public to learn the latest research advances in prevention directly from expert voices from around the world. So as you can see here on the screen, we are absolutely thrilled to welcome Dr. Lucile Adams-Campbell and Dr. Chiranjeev Dash from Georgetown, Lombardi to present Fierce Exercise Study, a community-based cancer prevention trial in metabolically unhealthy Black women. Dr. Brian Kim, Program Director of the National Cancer Institute, will introduce our speakers shortly. And before we get started with the presentation, I'd like to go over just a few logistics for today's session. All lines will be muted upon entry and will stay muted throughout the session. There will be a question and answer session at the end of the presentation, so please submit any questions you have to the Q&A pod directed to all panelists. And you can open the Q&A pod as I've displayed here on the screen. ODP staff will monitor these during the session. So while our guests are speaking, you will be able to focus on them by going to the top left of the page, pulling down the View menu, and clicking Hide Non-Video Participants. Please note that this webinar will be recorded and be posted to the ODP website and YouTube channel. Okay, enough of that. I know everyone's very excited about today's presentation, so I will pass it over to Dr. Kim to introduce our speakers. Take it away, Dr. Kim.
Great, thank you, Jenny. Hello, everyone. My name is Brian Kim. I'm a Program Director in the Division of Cancer Control and Population Sciences at the National Cancer Institute. I'm thrilled and honored to be introducing two distinguished investigators, Dr. Lucile Adams-Campbell and Dr. Chiranjeev Dash. Dr. Adams-Campbell is the Associate Director for Minority Health and Health Disparities Research, Senior Associate Dean for Community Outreach and Engagement, and Professor of Oncology at the Lombardi Comprehensive Cancer Center at Georgetown University Medical Center. Dr. Adams-Campbell has received numerous awards and honors to her contributions to the areas of health disparities, including the election to the National Academy of Medicine and named the 2021 Fellow of American Association of Cancer Research Academy. Her areas of research focuses on addressing health disparities with an emphasis on clinical trials and cancers that disproportionately impact minority underserved populations. Dr. Campbell also serves on the Board of Scientific Counselors of the National Human Genomic Research Institute and is the chair of the Alliance Health Disparities Committee. She has been involved in large epidemiological cohort studies, including the Women's Health Initiative and the Black Women's Health Study, and currently serves as a principal investigator of the National Cancer Institute's Community Oncology Research Program and the Howard-Georgetown Collaborative Partnership in Cancer Research. Our second speaker is Dr. Chiranjeev Dash. He's the Director of Community Outreach Engagement and Assistant Director of Health Disparities Research at the Office of Minority Health and Health Disparities Research at the Georgetown Lombardi Comprehensive Cancer Center. Dr. Dash is also a member of the Cancer Prevention and Control Program as an Associate Professor of Oncology and is a secondary appointment in the Department of Biostats, Informatics, and Biomathematics. Dr. Dash's research primarily focuses on molecular epidemiology and cancer prevention and control in minorities and underserved populations. He directs the Cancer Center's community outreach and engagement efforts in Lombardi's catchment area. And in this role, he also supervises and collaborates with community outreach staff to recruit participants, especially those from underserved areas, for epidemiological and interventional research in cancer prevention and control. So with that, I'll pass it over to Dr. Adams-Campbell and Dr. Dash to hear more about their Fierce Exercise Study. Dr. Campbell, Dr. Dash, please take it away. Thank you.
Thank you so much, Dr. Kim. I actually enjoy seeing you in this role. It's very fitting for you. Well, today, I want to thank the organizers for inviting us to present. And we're going to present about our Fierce Exercise Study. But more importantly, we're going to talk about a community-based center prevention trial in metabolically unhealthy Black women. And this involves community-engaged research. And I will say at the outset, community-engaged research is not for the faint of heart. It takes a lot and much more than what people really expect. Neither Dr. Dash nor I have any conflicts of interest to disclose. I'll give you a brief overview. The breast cancer burden and disparities in the DC metropolitan area where we're located here at Georgetown Lombardi Cancer Center is very pervasive. Obesity, physical activity, and metabolic syndrome we'll talk about. Community engaged research on cancer disparities, and more specifically, we will talk about the FIRST trial from design, eligibility, methods, and results. And you'll see how, I guess, expansive it is to get this type of study done, particularly focused on minority populations. Community engaged research. This is a CDC definition, the process of working collaboratively with groups who are affiliated by geographic proximity, special interests, or similar situations. And if you can see the little figures here, this CE represents community engaged research, but it's not just an island. It really, if you see all the concentric circles around, it includes policy and advocacy, research, clinical care, education, as well as community outreach. And outreach is very big. And you just don't go into a community and say, I want to do this study. The communities are very smart. They do not want to see helicopter science. You do not want to see somebody from Georgetown swoop in, literally, collect some blood or samples, and then leave them alone. It takes a lot to establish partnerships, collaborations, in order to make any of this research happen. From the perspective of a cancer center and our comprehensive cancer center, we have to define our community, our population that we are really entrusted to serve and that utilizes our cancer center as well. And you'll note that for Lombardi Cancer Center, I can tell you over the years, I've been there 15 years. When I first started, the catchment area included only the area around Georgetown and Northern Virginia for the most part, and Montgomery County. But now you'll see with this map that all the areas that are darkened, and that is our catchment area. And that comprises a large minority population. You'll see the catchment area cancers are 34.4%, and overall, about 50% of our catchment area is Black. And that's the focus that we've had to deal with, which means we've had to partner with many organizations and institutions to really establish a great relationship such that we can do research in these communities, with these communities, and for the communities, but not in lieu of their support and their endorsement. If you look at the cancer burden, the incidence in DC, and we'll focus on females because the FIRST study is all about women, you will see the typical breast, lung, colorectal, uterine cancer is very high in the DC area, as well as prostate and pancreas cancer, And for whites, you see the difference. The breast cancer, we've always said that breast cancer is in Blacks has a lower incidence than whites, but a higher mortality. Now we have to say that the incidence is even surpassing whites for breast cancer among Blacks. And the mortality still is very high. So that sets out to be one of the major areas of focus that we have continued to study. And we hope to try to eliminate some of the disparities sometime soon, but the rates are increasing, but the mortality rate is not decreasing. We have to really think about that. When you think about the mortality, here it is. Look at the mortality rates between Blacks and whites. The brown versus the blues. All the browns are higher. And that's really a travesty. So we're trying to do different things, maybe some novel things, some innovative things. How can we prevent the cancer so we don't have to even get to this point? Those are things that we must really, really think about doing. And when you talk about geographic disparities, okay, we can say Washington, D.C., but we know that Washington, D.C. is divided into 8 wards. And Ward 7, and this is east of the river, you hear them talking about the river, Anacostia River, has the highest incidence rate of breast cancer. And those are the dark colors that you see here. But Ward 5 has the highest mortality rate. So even when we talk about doing work in the community, we need to know more about the precision of what's going on in each of the wards if we want to effect a change. So if we talk about, we're going to do something in DC, let's make certain that we target the right areas. that really need the help and warrant the help. Some of the lowest areas are in the little pink, and you'll notice those are probably closer to the Georgetown University area. So we've gone away from Georgetown. We created our own, and you'll hear about it in a minute, center. Knowing that cancer disparities exist, and just looking at thinking about the charts I've just showed you, why do U.S. cancer health disparities really, truly exist? And if you look at it, some of them are environmental factors. The community has called upon us to actually conduct environmental studies where we do pollution monitoring in the house and outside the house. These are things that the community want. So sometimes, even though we're on a trajectory of what we need to do for our science, we must accommodate and address the issues right up front from the community. And we've done this in our own way of creating a needs assessment in the community, and we find out what has to be done. You'll see, but up top, the behavior factors. That's where we are targeting and focused today. And diet and obesity and nutrition, all those behavior factors that are so important in determining what happens in your health outcomes. But there are other factors, social, clinical factors, and cultural factors. And cultural factors become very important. If you're not familiar with the culture, we don't become cultural competent in somebody else's culture, but we have to recognize and appreciate and accept that the cultures do differ. And what do we have to do to be accommodating to different cultures? Everybody has different beliefs, and we can't just decide this is the way it's going to be done, and that's it. So those things are very important. If you look to the right on the diet, nutrition, physical activity, and postmenopausal breast cancer slide, just showing that there's strong evidence that body fatness is a major risk factor for breast cancer, and physical inactivity, well, physical activity is very protective of breast cancer. I'm beginning to resent these maps. They come out faithfully every year, and you'll see that on the left, the non-Hispanic white, on the right, the non-Hispanic black. Every year, these maps get darker and darker and darker, indicating the higher percentage of people that are obese. And the darkest is greater than 40%. So if you look to the right, blacks have a very high rate of body fatness, obesity. If you look to the left, the non-Hispanic white population doesn't look like this. But I can tell you 30 or 40 years ago, this map used to be light blue and white, where there was virtually no problem with obesity. So over about 4 decades, we have seen the rise in obesity and supersizing your drink. And if you look at the little bottom, this little DC on the left for whites, obesity is not a big issue. But on the right in DC, the little bottom DC sign, obesity is very big problem. So again, if you don't look at and drill down and look within or between different race groups, it can be between different gender groups, you won't notice these little details such as this one. So DC up top, yeah, it's a problem, but the whites do not suffer as much as the blacks by any means. So those types of details you only find out by drilling down and really looking to see what problem you're really addressing, even in your catchment area. So we've decided to talk about metabolic syndrome and breast cancer. We know now that obesity is linked to approximately 13 cancers. But when you think about obesity and you think about comorbidities and all the coexisting diseases, you decide to look at it from the perspective of metabolic syndrome. That's what we've taken that approach. And you can see even at healthy weight, people can have metabolic syndrome, increasing risk for certain cancers. Like here, you'll see that you have high blood sugar, high blood pressure, maybe. Low HDL, that's the good cholesterol. If you have a low amount, that can increase your risk and development of metabolic syndrome. High triglycerides, and excess fat around the waist. And to your right, you'll see the different pathways, the different factors that are involved in this metabolic syndrome with obesity, whether we're talking about T cells or macrophages or adiponectin or leptin. and you see the tumor necrosis factor alpha, or diabetes, insulin, IGF. You see that little group coming into play. Hypertension, dyslipidemia. All these items and issues are so relevant to metabolic syndrome. So even from a community engaged side, and I think when people think about community engaged research, they think that we go out, we meet, talk to people and all, and come back, and all qualitative. I'm not against any qualitative data, so don't get me wrong. But I think that people do not realize that there's a lot of knowledge to be garnered from the community. And sometimes people think community engaged research is not scientific enough. You can make it as scientific as you want to, as detailed as you want to, as basic or molecular as you want to, because everything is there. It's just that many times they still can be too few to count when it comes to whites. And we have made it our point to focus on minorities, particularly Blacks in this study, as well as Hispanics. But you have to be intentional when you want to address these issues in minority populations that have been relatively understudied. Well, you know that energy balance, caloric intake, caloric expenditure. Well, this is related to physical activity as well, in inactivity. The same patterns, the darker the color, the more prevalent of physical inactivity. And again, at the bottom on the left, non-Hispanic white in DC, very active. If you look at the bottom on the right, physical activity in DC, poor, very poor. So we can tell from the obesity charts, from the physical inactivity charts, this is a major area that needs and warrants considerable attention by many people. To come from it from different aspects. How do we address this? If we're talking about prevention, preventing cancer, these seem to be key targets that we should never overlook. What's the significance? The disparities in obesity and related metabolic abnormalities and physical inactivity leads to breast cancer disparities. We see them, but we see them more now in mortality. Interventions to increase physical activity and reduce metabolic syndrome in postmenopausal women could be a very effective prevention approach. And there's evidence in Black women limited and strong support for community-based translational research. And we have a community advisory council that really helps keep their fingers on the pulse of the community, and they transmit that information to us so that we know what's going on across DC, across our catchment area, Blacks, Hispanics, Vietnamese, Chinese. We make certain that we have a community advisory council that is very diverse, very representative of our catchment area, so that we can get the information we need and work together. We give out community projects to pilot projects to the community so that they can develop some little projects that we can take back to the science, to the bench, to the clinical, and do more with. And we wanted to look and see, is a community-based exercise intervention in Black women who are at increased risk for breast cancer effective in modulating metabolic syndrome? The one thing people always say that, well, Blacks are very less likely to participate in studies. And I always say, do you invite them? Do you have the eligibility criteria that makes and warrants their interest in participating in your study? And did the study emerge somewhat from the community? Is this something that the community is interested in and very helpful and very much needed in our research and in our science, in our cancer centers? We want to know, will a home base, less resources needed for exercise intervention be as effective as a supervised facility-based intervention? So you have the less resource and the more resource intervention arms. We wanted to test all of this. We deal a lot in reality. Reality, I feel that Blacks are always behind, minorities are always behind, never up to par with everybody else, never being included, never being engaged. And I can tell you, people like us being engaged with them. So we want to get away from this reality. And equality doesn't really work because we really need equity, something that is really precision and targeted to individuals so that they really see and benefit equally across in an equitable situation for everything that we do. So when I came to Georgetown after leaving as director of Howard University Cancer Center, one of my requirements was, but we had to have a community-based office. There's no metro at Georgetown. It takes a long time to get there from Ward 7, Ward 8, from the communities that we want to engage in Prince George's County. It takes a long time. So we were given an office out by the Nat Stadium. When we moved to the Nat Stadium, we didn't have any problem because we were great being in Southeast, and it's the 1000 New Jersey Avenue Southeast. That's where our Georgetown University community-based office is, and we have a very diverse group. And I was involved in this paper involving minority and underserved populations in cancer clinical research, and we've always been intentional, and we've also always met our goal. So Dash will talk more about our office, but we're pleased that you might have read that we now will change our Office of Minority Health and Health Disparities Research to become the Ralph Lauren Center for Cancer Prevention, because they have decided to support our efforts to expand our outreach. Located in Southeast DC, and as I mentioned before, we have to address cultural competency. Speed up a little bit. And here, this led us to the P60 grant, the Center of Health Excellence for Health Disparities. And this was a project that was done in collaboration with Howard University, MedStar Health, our CTSA that's between Georgetown and Howard. So we've done a lot together to build a P60 Center for Excellence for Health Disparities. And that's why we are focusing today on the FIERCE study, Focused Intervention on Exercise to Reduce Cancer. And now I will turn it over to Dr. Dash to go from here.
Thank you, Dr. Adams-Campbell. As Dr. Adams-Campbell mentioned, FIERCE study was one of the projects within the Center for Excellence for Health Disparities funded by the NIMHD from 2012 to 2017. And it was a randomized clinical trial whose aims were to compare the impact of a supervised exercise program with a home-based exercise program compared to a control group. And our primary outcomes of interest were obesity, metabolic syndrome components, and breast cancer biomarkers. Today, my presentation will focus mostly on metabolic syndrome. So this is just a brief overview. It was a 6-month, 3-arm randomized controlled trial. We were comparing 2 exercise-based groups to 1 wait-listed control group. The supervised facility-based group had to come to our lab within the center, the community-based center that Dr. Adams-Campbell was showing you earlier. So the target for that group, all of the participants were sedentary when they started the study, and the plan in concert with our exercise physiologist was to have them exercise about 75 to 150 minutes per week, moderate intensity aerobic activity. And here are some of the details of that. The home-based exercise group also tried to target the same amount of moderate intensity activity, but instead they were given resources and given help, including text-based messaging and being shown where they can walk in their neighborhoods. And primarily walking was their exercise of choice. And their target was about 7,000 to 10,000 steps a day, which correlates with about 150 minutes per week of activity, moderate intensity activity. The control group was asked to maintain daily activities, and all groups were asked not to change their diet. So the inclusion criteria, as Dr. Adams-Campbell mentioned, we were focused on reducing disparities, and this was a minority-focused grant, so it was all African-American women. They had to be postmenopausal between the ages of 45 to 65. They had to be at higher risk of projected cancer based on the National Cancer Institute's breast cancer risk assessment tool, and they had to be metabolically unhealthy. So they had to have a waist circumference of more than 35 inches, which is the definition of abdominal obesity in females. And in addition, they had to have at least one of fasting glucose or blood pressure greater than equal to 130 systolic or 85 diastolic. You will see that we did not include a triglyceride or a lipid inclusion criteria, and I'll talk a little bit about it in the next slide. The exclusion criteria were they could not have cancer or any history of cancer, they could not be on anti-diabetic medications, and that if they were currently exercising or could not commit to an intervention schedule, then they could not take part in the study. The reason we did not include a triglyceride or a HDL inclusion criteria is what you're seeing here, and please only focus on the red curve, which is for non-Hispanic whites, and green curve, which is for non-Hispanic blacks. If you look at it, in general, non-Hispanic blacks have slightly higher abdominal obesity. Definitely, they have higher elevated fasting plasma glucose compared to the whites, which are in the red curve. They have more likely to have hypertension. But if you look at triglycerides and reduced HDL, in general, African-American women are less likely to have elevated triglyceride, less likely to have reduced HDL. And that's been an issue in how we define metabolic syndrome, which says 3 out of 5. But if 3 out of 5 includes these two, triglycerides and HDL, it's less likely that African Americans are diagnosed as having metabolic syndrome, even though they have higher risk of cardiovascular and other chronic diseases associated with metabolic syndrome. So instead of looking at the actual cutoffs for metabolic syndrome, we decided only to base it on abdominal obesity, fasting plasma glucose, and hypertension, and not take these two into account in terms of inclusion. But we do look at the results of triglycerides and HDL when we did our intervention. So the recruitment was all community-based with the help of the community engagement core of the Center for Excellence. Here is an example of a postcard. This is just one of the recruitment tools we used. We actually handed out about 30,000 of these postcards. So we had recruitment strategies in multiple places with multiple involved community outreach personnel. The screening process was two-step. Participants who saw or heard about our studies, either through word of mouth or through this postcard, would call into our office to be screened over the phone and give us self-reported data. But then they had to come into our office to make sure that we got other lab measurements to see if they would be eligible for the study. So the assessments, once they came into our office, was medical history, demographics, a bunch of anthropometrics, including body composition using dual X-ray absorptiometry. We measured blood pressure, heart rate. We measured VO2 max. We got their self-reported 7-day physical activity recall. They filled in African-American specific block food frequency questionnaire, health-related quality of life, and then we took a fasting blood sample. So as I've said before, our primary outcome was metabolic syndrome, and this is how metabolic syndrome is defined. You have 5 factors that correlate with each other, that are syndromic, that cluster together: waist circumference, fasting glucose, systolic and diastolic blood pressure, triglycerides, and HDL cholesterol. So when you look at metabolic syndrome, mostly in the literature, it's a dichotomous variable. 3 out of 5 of these means you have metabolic syndrome. Less than 3 means you don't have metabolic syndrome. So to make our analysis slightly better, and as others have done, what we also did was took all these variables and created a continuous Z-score using these cutoffs and the standard deviation in our population. And I'll show you results both ways. So this is our screening population. To get 200 odd participants, we actually screened 1,500 Black women. This is all through community-based recruitment. And if you look at the characteristics of our screening population, you'll see that our community outreach efforts were successful in trying to find the population we were trying to find. About 85% of them were either overweight or obese. 60% were hypertensive. 41% had a history of hypercholesterolemia. And if you look at it, initially when we started the study, we were using a cutoff for the risk assessment to be 67% higher of absolute risk, but we found out that that would severely limit the number of women we could recruit into the study. So after about a couple months, we reduced that cutoff to about 40% higher absolute risk. So I'm not going to go through all the details of this CONSORT diagram. We started with 1,500 women, 430 were eligible after phone screening. As you can see, we lost quite a few women because they were unable to come to our center for in-person screening. But once they were there for in-person screening, out of 261, we managed to enroll 213 women who finished their baseline assessment. 71 were in the control group, 69 in home-based, and 73 in the supervised group. After a 6-month follow-up, this is a community-based effectiveness study, we lost about 23%, 26% to loss to follow-up, 3% decline to return for follow-up visits, and we could not reach 23% after 6 contact attempts. Here are the baseline characteristics. You'll see that the age group was around 58. The mean age group was 58. About 45 to 50% of the women were either current or former smokers. The body mass index was close. The average body mass index was 36. And, they were obviously not exercising before at the start of the study. They have a slightly higher total energy intake, and about 40% of them, 30 to 40% of them had a family history of breast cancer and first-degree relatives. Here are the results of the study, but before I start, I'll show you this oval, this blue oval shows you that even though it was a block randomized study, there was some imbalance recruitment through assignment across the groups. You can see that even at the start of the study, the supervised group was slightly healthier as far as metabolic syndrome goes compared to the home-based and the control groups. The control group is the gray curve, and you can see that over time, from baseline to 6 months, the proportion of participants with metabolic syndrome remained unchanged in that group. And in both home-based and the supervised group, that proportion decreased. And when we compared the decrease compared to the change in the control group, it was statistically significant. If we then looked at whether the changes had anything to do with risk of breast cancer or with family history of breast cancer. And we found that we saw much stronger effects of the home-based intervention, specifically among women who had a family history of breast cancer, compared to those in the control group. Those in the home-based group, actually with a family history of breast cancer, were less likely to have metabolic syndrome at the end of the intervention. The results were similar in those without a family history of breast cancer, but it did not approach statistical significance. If you look across the multiple components that go into metabolic syndrome, I'm not going to go into details, but you'll see that most of the changes for waist circumference were very minor, and they weren't really different across the 3 groups. For the fasting glucose 2, it was the same story. Most of the changes we saw were changes in mean arterial pressure or blood pressure in the supervised compared to the control group, and in triglycerides in serum, for both serum triglycerides and serum HDL. So even though I showed you, remember that people start with what we would consider as normal levels, with exercise, they actually changed and got to a healthier level of lipid profile with both our home-based and supervised exercise interventions. When we looked at metabolic syndrome as a continuous Z-score, an increase means higher risk of metabolic syndrome. You will see that the control group, denoted in blue, actually had, at the end of the study, over the 6-month follow-up, actually increased the risk of metabolic syndrome, but the changes in both the exercise groups were in the direction we would expect, that is the lower risk of metabolic syndrome over time. And this was much, much stronger in both the home-based and the supervised group compared to the control group. Whenever we give this presentation, people ask about what happened to weight. And this is what it's showing. Here's the first bar is the BMI in kg per meter square, and the rest two are DEXA measurements, lean mass in kilograms and fat mass in kilograms. What you will see is there was no clinically significant difference in weight or BMI across the three groups. Does this mean people didn't lose weight? Well, that's not true, but on average, their weight change was not different across the three arms. And it's the same story if you look at it through lean mass or fat mass changes. However, when we looked at systemic inflammation, one of the biomarkers, I don't have time to talk about all the other biomarkers, but when we looked at high sensitivity CRP, which is a biomarker of systemic inflammation, we did see changes in the right direction for both home-based and supervised group. But we also saw a big difference in the control group, which resulted in the decreases in the intervention groups not being significantly different from the control group. We think this might be related to if you look at weight change in a slightly different way. So we looked at percent weight loss from baseline weight in participants who had no weight loss, less than 5%, 5 to 10%, or greater than equal to 10% weight loss, which is considered highly clinically significant. What you'll see is that 35% of the control group actually lost more than 10% of their weight, which is less than 39% in the home-based group and 45% in the supervised group. So there is a group of women who actually significantly lost more than 10% of their baseline body weight, but the weight change was not significant because of possible contamination in the control group, as all of the people who took part in our study were highly motivated to change their behavior. So that's our study. I would really like to acknowledge all the staff of our office that Dr. Adams-Campbell showed you, our exercise physiologists, our biostatisticians, our community outreach people. But overall, the picture I'm showing you is of Vicki Watkins. Vicki Watkins was the coordinator for recruitment. And we lost her to breast cancer and blood cancer a few years ago, and that was a devastating loss for us. This study could not have been possible without her. And in fact, when she was getting treatment and in the hospital, she was still calling participants and recruiting and making sure they come in. I would also like to acknowledge our collaborators in Howard University. Dr. Shepard, who is now in VCU, was with us back then. Dr. Jim Hagberg, who was the exercise physiologist on the study from the University of Maryland. Dr. Jason Humans, in whose lab we got all the biomarkers were measured from MedStar Health Research Institute. And last but not the least, your own Dr. Brian Kim, who was involved with us. He did a lot of the DEXAs, the results of which you saw. He did some of the VO2 max studies, and he moved over to the funder side from the fun side. But that's a conversation for another day. We also would like to acknowledge funding support from the NIMHD and the NIH-NCI for our cancer center. And finally, to all the participants from our FEAR study, what you see here is an infographic we had shared with them after the study was done via our newsletter to the participants on what we found in the FEAR study. And the feedback we have gotten from them is, what are you doing next? So we are moving forward with community-based programs on exercise that would give access to exercise to multiple participants in the community, not through a research study like this, but maybe through a dissemination and implementation study. So I would stop there, and we welcome all questions.
Thank you so much, Dr. Adams-Campbell and Dr. Dash, for this wonderful presentation and really lending your expertise and reminding us of the importance of doing this community-based work and the amount of care that is needed to do this work. So as a reminder, we're moving on to the Q&A session. So please submit your questions into the Q&A pod directed to all panelists. I've seen a few questions come in, so I'm going to go ahead and ask those while others, get their thoughts together and put their questions into the Q&A pod. But one question that came in is, this was a terrific presentation. Since metabolic syndrome is a system dysregulation that increases aging, do you have any banked pre-post bank specimens we could use to test epigenetic age changes?
That is a great question, and if I didn't know who asked this question, I would go to one of our collaborators from Georgetown University. But yes, we do have serum from the study, and what we are doing now is we are doing metabolomic assessments to look at um, changes in some of the metabolites associated with aging. Some of the things we wanted to do, for example, look at telomere length, or some things that would require actual cells we do not have access to, but we do have access to serum, and we are more than happy to collaborate with anyone who is looking at that. But yes, as we now have a Georgetown Center in Cancer and Aging, and we are really interested in any aging related minority health research around health disparities. So thanks for that question.
Great. Another question that came in. So for LTF, any speculation about why they lost interest and were rates equal across groups? Did they drop out early on?
Yeah, so one of the things, this was always going to be an issue. We were convinced that we would do it a community-based study, which means that people did have a burden to come into our office, but also sometimes a burden when we were asking them to walk and living in neighborhoods where it's not easy to walk around. What we have seen, we tried a few things. We tried to have text messaging to keep them engaged even throughout our process. We did not see a higher dropout in control group versus the other two groups. It was roughly equal in all three groups. We did also give we also provided support for travel through both metro or through other travel back in 2013, 2014, but it wasn't really a big issue. The biggest issue, I think, was not being able to contact people. And through our other navigation processes, we have seen that sometimes it gets really hard as people have unstable telephones or unstable connections, and it gets really hard to contact them.
Let me just add, I think it's really important to understand that our home-based group had the best outcomes. And that's really important when we talk about what we can export to the community. Coming into the office requires either driving and finding a parking space. Now that the Nats are back in session, we had to do so much coordination. That's tough. But when you learn that the home-based group had the best outcomes in this intervention, I think that we have to really rethink how we do our exercise interventions, and we are working on that right now. Some telephysical activity interventions we're trying to do now. So this study has really changed how we think. So has COVID. So that's all been important.
Yeah, that's a great point to highlight that those differences really emerge for home base as opposed to supervised, and that might afford more people to really engage in these practices more readily. All right, so another question that came in. Would you explain in more detail how the community advisory panel operates within this community?
Okay, I guess I'll take that question. The Community Advisory Council is chaired by a member of the community. Right now it's chaired by Melanie Nix. Those of you who remember Zora Brown, who was the big breast cancer advocate, it's her niece, who's also a major breast cancer advocate in the country and does well. But we identify people from different walks of life, whether they're in media or a public housing resident or business. We just try to get those groups together. We meet quarterly. And we meet and we treat them like any other board. When we come to a meeting for board meetings or community council meetings, we pay them to sit there and give us their input and their ideas. We engage them in our needs assessment, so it goes back to the communities that they serve. That's why it's really important that our Community Advisory Council is represented across our catchment area. We do have a couple of doctors, community-based doctors on the Advisory Council. We have a couple of media people on the council, and it helps distribute and disseminate our information, our knowledge across our catchment area. We meet, like I said, quarterly. We discuss topics that they put on the agenda. that come out of the previous meetings or topics that have happened in the community. COVID, I can tell you that the chair of the our community advisory council, very clear in saying she had no plans of ever getting the COVID vaccine until I talked about the virtues, talked about the comorbidities, talked about the benefits, talked about how minorities are dying at an alarming rate from COVID, and come back and find out the council is vaccinated. Things like that are really important. So we take to heart what they want to talk about and the issues that are on the table. And we also bring the science to them. We also made certain that now we've started every meeting, a scientific presentation is given, just so they can be up to date. It'll be presented in a lay term, but it could be on colon screening, on prostate cancer. It could be on different topics. It could be on COVID, but just so that they understand it from a relatively scientific level that reaches them and targets them, and then they come up with more ideas. So we integrate our scientists with our community advisory council so that we can learn from each other. In fact, we have a liaison committee, and we are worried about and focused on bidirectional science. It's really important to us. So in order to do bidirectional science, you have to have the scientists listening to the community and community listening to the scientists. And we're developing projects that way as well. Dash, you might want to add to that?
No, that was great. I think we can move on to the next one.
That is great. That does sound great. Like a great collaboration. So there's a lot of questions that are coming in around your home-based intervention. One question here is that they just want to know more about it. So how was it facilitated, basically?
Sure. So the home-based exercise was supposed to be a low-resource intervention. And what we did was, after they had their VO2 max testing, the exercise physiologist worked with individual participants, and they took about 2 weeks for them to build up to the target moderate intensity activity rate. So their primary goal was being taught what brisk walking means by the exercise physiologist, and to use brisk walking as the primary goal. Before that, all of them were cleared by our nurse practitioner on the study to see whether there were any absolute or other contraindications to exercise. They were all given pedometers, which is not as which is really low tech. They were all given pedometers, exercise diaries, and they were also given, based on where they lived, some routes around their areas, including indoor walking routes near the malls or other places that they could use. So all they were supposed to do was report to us through text messaging their pedometer reading at the end of certain days when they were prompted, keep an exercise diary that they brought in, but we also reminded them through text message, did you walk today? Today was your day to walk. And what we saw is that compared to the supervised group, who were required to come in 3 times a week, most home-based group participants who were actually maintained fidelity to the intervention ended up exercising more days than the supervised group. So most of them were exercising between 3 to 5 days versus 3 days for the supervised exercise group.
Great, thank you. Some questions about your results in particular. So could the weight loss in the controls be related to decreases in muscle mass and not fat mass? Did you guys assess that?
Yeah, so one of the graphs I showed was from muscle mass and fat mass, lean mass and fat mass, and that's why we did the DEXA. Again, if we look at it overall across the 3 groups, there were no changes. There were no statistically significant changes between the groups in change in lean mass or in fat mass. But if we look within the groups, the supervised groups, there were the proportion of women who were more likely to gain lean mass was highest in the supervised group, and the proportion of women who were more likely to lose fat mass was in the home-based group. The control group kind of maintained it, and they did lose over time. Almost all groups, all women actually lost a little bit of lean mass than before, except the supervised group.
But I do think that the one point that is borne out from all of this, that perhaps 6 months is just not long enough. we need to extend our time frame. And what we're doing towards that is we are doing a follow-up, just got IRB approval to actually go back and call the women back in. And let's see what's really happened. I hope they all haven't increased weight, but I can tell you anecdotally, many women kept on exercising and kept the weight loss going. In fact, one woman lost close to 100 pounds post our 6 months. So we're trying to capture that now, and we're doing a follow-up.
One other point, DEXA really helped us keep the women motivated, because at 3-month level, when people got on the scale and said, my weight hasn't changed, this is not working, we could show them the DEXA showing that in many cases, fat mass had actually decreased and lean mass increased, which is why the overall weight did not change. So we did use DEXA successfully as, for some of the women at least, as a tool to keep them interested in the study.
Yeah, there seems to be a lot of interest in your weight effects. That's great that you noted what the future is of this work, at least a little bit here. All right. Let's see. Another question about your weight effects. Did you observe higher changes percent weight for subgroups within higher baseline weight?
Yeah, so that's a great question. So one of the things we did, and if you remember, I showed you the disbalance in the randomization, at least in some of the metabolic syndrome component. So all of our analysis controls for baseline weight or baseline blood pressure or baseline metabolic syndrome. So even when I show you changes for weight, we do control for baseline weight. But in general, yes, for most groups, the greater than 10% weight loss was in women who were mostly more than 90% adherent and who started with a higher baseline BMI, as we would expect. Yes, that was true.
Great. Now, another person's curious about the fidelity of your intervention. So did you assess this? And they go on to wonder whether or not assessing the fidelity can contribute to the improved outcomes, particularly in your home-based intervention group.
Correct. So as I said, the way we assessed fidelity was going through their self-reported pedometer targets and their exercise diaries. What we noted was that although we had asked them to keep an exercise diary for every day, by 3 months, it was clear that they weren't doing it for every day. So we moved from 7 days to 3 days a week. And then we saw a slightly better adherence with reporting. But the text message based reporting for the pedometer is the one which we used for adherence assessment and for fidelity. And for those women who were not lost to follow up, we had about an 80% adherence fidelity rate, which we defined as at least 2 days of exercise in a week.
Got it. Thank you. So some questions about your control group. So this person thinks they saw in the control group that the prevalence of metabolic syndrome increased substantially in just about 6 months. Is this the case? Do they recall correctly? And if so, why would that be so rapid?
Right. So we did increase it, but you'd have to again remember that it could be an artifact of who we might have lost to follow-up. However, the reason why we saw an increase in metabolic syndrome was related more to lipid profile and to hypertension than to plasma glucose or weight change. So the weight change, as I showed you, wasn't different between the three groups. Plasma wasn't different. We saw increases in hypertension and in lipid profile in those groups. But again, I won't say that it was very highly that big increase was probably because of who we lost to follow up in some case.
And also sometimes we looked at metabolic syndrome, yes, no, and it's easy to add another variable and end up being a yes very quickly.
Right.
So how you look at it and how we interpret it.
But when we looked at it as a continuous scale too, it was less steep, but
yes.
it was there.
Mm-hmm.
Right. So, Dr. Dash, this is for you. So, this person thinks they heard you say that this was a quote, highly motivated study population. So, this person goes on to wonder, were measures of motivation, self efficacy, or confidence or social support included to measure how cognitive factors may have influences behavior or study retention.
That's a great point. If we were to do this again, we would definitely add it and not keep it as the quality of life and SF-36. What we did do was we did do an exit interview after the study was done. Obviously, we couldn't capture everyone who came to baseline, which we would have really loved it. But we did get the feedback from women who actually completed the study. And what it turned out was that there was not much that influenced whether they participated or not. It was mostly women who said, this is a great study, and we were really motivated to participate. And the control group appreciated all the things they got at the as waitlisted control group, which was everything that the home-based group got. But yeah, we do not have data on self-efficacy or social support, and we would really going forward, if we do the study again, we would really collect that data.
But also from the prevention side, I think for probably most populations, those that participate in prevention studies, clinical trials, are highly motivated. I don't think it's unique to our population. I just think this is the one time we're engaging this population at this level.
Great. So I think we only have time for one more question, so I'm going to try to squeeze it in before we close out the session. So last question here. So the community, the advisory members, the community that you partner with in general, are they involved in your data interpretation? Are they involved in your publication process of study results?
Right. So in this study, they are, let me think.
Trying to think about that too.
Yeah. So for this study, so this was not a community-based participatory research study. We put it as a community-engaged research study. We have other studies, like Dr. Adams-Campbell mentioned, environmental study. We have a breast cancer screening study with their co-authors on us, but not on this study. We did take their most of the work that was done by our advisory council was really helpful in the recruitment stages and the planning stages, because they would tell us, here are the places where your community outreach people should go to recruit. Here are the avenues where this should be done. And they were vocal supporters of us in some of their churches, in some of their communities, and other places where they allowed us to come and give presentations. But no, I would say that this was not a CBPR study.
And just so we can acknowledge, we do have those studies, like the BSERP study in particular, that the Breast Cancer Environmental Research Project, where the community is a key driver of that study. They co-author, they are funded as well to be our partners. And that's one thing that we do focus on, funding partners as the studies evolve from those communities. But this study was set up very differently. And it was also the first study we did and launched when we first moved to our community-based office.
All right. Well, thank you so much. I saw a few more questions pop in the chat. I'm so sorry we ran out of time, but we will collate these questions and send them to our speakers. And if they have time, they can graciously respond and we'll post them to our website. So I just wanted to thank everyone before ending. Thank you to our speakers. That was fantastic. And all of you for participating and attending. So as I mentioned, a recording of this webinar will be archived and shared on our website, noticed here on the slide at a later time. So if you have any questions about the Prevention in Focus webinar series or would like to receive a copy of our slides or have any questions in general, please contact the Prevention in Focus email address presented here on the slide. And thank you again so much to our speakers. We look forward to seeing you for the next webinar in the summer. Stay tuned. Thank you so much again.
Thank you
For having us.
Thank you.